Okay, this is Dr. Ayub. So today I will cover the small parts, that is thyroid and parathyroid glands, ultrasonography. So thyroid and parathyroid glands, both of them are endocrine glands. So we have to understand that there are major 6 endocrine glands, and the thyroid and parathyroid are among them, and the rest of them are pituitary gland, then islets of Langerhans, then adrenal glands, and the gonad for the man it is testicles, for the female it is ovaries. Okay, so that's the way the 6 major endocrine glands we need to know. Thyroid and parathyroid glands are very important for that reason that a lot of patients you will see in your clinical job or clinical life, then a lot of people come with the complaint of something wrong in the neck and in front of the neck. There are a couple of causes that it bothers the neck, but one of the major cause is diseases of the thyroid gland. Thyroid gland can have infection, can have a cyst, can have a tumor, and tumor can be benign, can be malignant. And there are diseases known as goiter. Some area in the world the goiter is too much. That goiter is benign, and that is the iron deficiency goiter or colloid deposition. But other than the thyroid enlargement due to goiter, this benign cause and the malignant cause are the main. So benign thyroid, we call it benign thyroid mass in the neck, we call it in the thyroid, we call it thyroid nodule. Thyroid nodule is very common, just like a fibroid in the uterus. But they grow slowly, sometimes it grow bigger, but sometimes it may turn into malignant. And malignant one are a couple of types, papillary types, medullary types, follicular types. So some of them are very frequently happen, some of them are very aggressive, and some of them are very fatal. And nobody wants a mass in the thyroid gland can be visible, can be palpable, and it can cause the cosmetic disorder, right? Cosmetic disorder. What is cosmetic disorder? I'm not going to go with the neck exposed and there's a mass in the thyroid gland, one-sided or both-sided, neck swollen. No, I don't like it. You might think, I don't like it. Then what's going on? I need to go to the doctor. Then you will see, you will go to the endocrinologist, then neck surgeon. So they will take this off. And before taking this off, they will do the evaluation. Pathological evaluation, blood work, and the biopsy, fine needle biopsy, aspiration, and they will do the nuclear test. Why they are doing all those things? Because they like to see, is it benign or malignant? If it is a benign, that's a good news that you can keep it. You can keep it until a certain size that is visible. But make sure you have to be followed up every 6 months. That is it growing bigger and all the sonographic feature is competent or compatible with the benign nature or malignant nature. Sometimes you will see somebody has the benign nodule overnight, in the midnight, is something bothering in the thyroid gland, in the neck, in front of the neck, and they feel like, what is this? And they squeezes, and they found that it's painful, it's warm here. So that nodule become hyperactive nodule, or it may turn into malignancy. So same thing, it happens like a fibroid in the uterus. So no benign fibroid may turn into malignancy. Same thing in the thyroid nodule may turn into malignancies. So for all these causes, the people wants to come to the doctor, and the doctor will evaluate by physical examination and the blood work, and doctor wants to see by ultrasonography, get the baseline study, and then we will do the follow-up. So that's why patient will come to the sonographers. And ultrasound is used for not only just taking couple of pictures from the thyroid gland and that's it. No. Ultrasound is used for the thyroid gland evaluation, thyroid gland biopsy, thyroid gland treatment evaluation, that treatment is working or not, then any what is this called, post-thyroidectomy evaluation. So couple of conditions they need ultrasonography. That's why ultrasound is more popular for the thyroid gland evaluation, and it is the start. That's why if you know how to scan the thyroid gland, then evaluation is much better. But before doing this thyroid gland evaluation by ultrasonography, you must need to know where is the location of the thyroid gland, what is its embryology, what is its anatomy, shape, size, what is its vascularity, what are the artery veins they supply, is there any important landmarks around the thyroid gland, so that I can scan the thyroid gland with the guidance of the landmarks. So there are a couple of landmarks we need to know, because sonographically you will see all of them. Then it will make your life easy. So, okay. So now we will start the thyroid gland from the general information. In the general information, we need to know location, we need to know the lobes, then we will go for embryology. Embryology or embryogenesis, then we need to learn the anatomy. In anatomy, we will learn the size, shape and contour, and we need to know the vascularity. In vascularity, we will learn the arterial and the venous. Then we will know the neurovascular bundles, and there is a major neurovascular bundle and minor neurovascular bundle. Okay, so then we will learn the landmarks. Landmarks. In the anatomy, we need to know the landmarks. In the landmarks, we need to know the vessels and we need to know the muscles. Okay, so that will conclude our anatomy. Okay, so this is very important, so let's discuss about this. Okay, so thyroid gland, where is it located? It is located, in short, if we want to understand the location, so then we need to keep in mind that it is located in the neck. It is located in the neck. Where in the neck? It is located in the neck anterolaterally. It is located in the neck anterolaterally to the trachea. Then it is superior to the clavicle and it is inferior to the hyoid bone. Okay, so now if I draw a diagram of the neck, okay, this is neck, this is clavicle, and from that clavicle just understand that this is a sternum. And the tracheal ring is here, and in the tracheal area you will see the hyoid bone. So it is hyoid bone. Then you will see the thyroid cartilage. Thyroid cartilage, you will see this is hyoid bone. And this is thyroid cartilage. And the thyroid gland, you will see this is thyroid gland. The common carotid artery on both sides, you will see the common carotid artery. And you will see the jugular vein, internal jugular vein, Okay, so now let me give you the name. So this is isthmus of the thyroid gland. So this is left lobe, this is right lobe, and 15 to 30%, 15 to 30% you can see the pyramidal lobe. Okay, these are the clavicle. Now this is common carotid artery on the right side, and this is internal jugular vein. Okay, in the neck you need to know this, and this is the face. Okay, this is the face over there. Okay, so this is neck. You need to know this landmark. Now the lobes, the location we got it, then know the lobes. It has two lobes. One is right lobe and left lobe. And 15 to 30% there is pyramidal lobe. Okay, pyramidal lobe, 15 to 30% you can see pyramidal lobe, and most of the time the pyramidal lobe arises from the left side of the isthmus. It does not arise usually from the left lobe, but most of the time left side of the isthmus. Okay, very rarely it may arise from the right side of the isthmus too, but most commonly it is on the left side of the isthmus. Okay, so this is lobe. So now I will talk about the embryology or embryogenesis. Oh, okay, you're gonna draw it, right?
Hmm?
Yeah, quickly.
Okay, I drew.
Okay, so now we'll talk about the embryogenesis. Embryogenesis for the thyroid gland is very important. Why it is so important? Because this is the first endocrine gland in the body to grow. And why it is first endocrine gland? Why it is needed? Yes, there is a reason. So it starts growing in fourth week, at the fourth week after fertilization, or sixth week by LMP. So embryogenesis is very important because there is also one congenital pathology related. Okay, so now it develops embryogenesis. It develops during fourth weeks and 6 weeks by LMP. and where it is developed, you have to understand. So it develops along with the tongue. I'm drawing that diagram. If this is the tongue and tongue is growing and the thyroid gland is also growing. Where? At the pharynx level. So now this is thyroid gland. This is tongue. So tongue is in the mouth cavity. Tongue is in the mouth cavity. But the thyroid gland is not in the mouth cavity. Where is it? It is in the neck, in front of the trachea, anterolaterally of the trachea. That means what? The thyroid gland has to descend. So it starts descending by the 7th week. It starts descending DES. It starts descending to the neck by 7th week or 9 weeks by LMP. So now it will descend, and this is thyroid gland. It will descend. This is thyroid gland, and finally you will see the final stage of thyroid gland is in the neck, anterolateral to the trachea. So now understand. So did you notice? It is attached with the tongue by thyroglossal duct. This is thyroglossal duct, and this duct is the inside. It is empty and it collects fluid. But after descending of the thyroid gland in its proper location, then this thyroglossal duct usually gets atrophy. Atrophy means vanishing. So now when this thyroglossal duct gets atrophy, just understand that. So this is tongue, and from this tongue so this is thyroid gland. So this is tongue, this is thyroglossal duct, and this is thyroid. When it is descended in the neck, then what happened? This thyroglossal duct gets atrophy, and it remains as a fibrous tissue, cord-like fibrous tissue, but is still attached with the isthmus of the thyroid. That's why when we move the tongue, we swallow. Look at here. We swallow. My thyroid gland, you can see. You notice something is going up and down. What is this? This is the thyroid gland. Why it's moving? It's moving because when I swallow, I move the base of the tongue forward and up, forward and back during swallow. So that pulls the thyroid gland up and down. I always do that. That if it is visible or not visible, I ask patient, swallow please for me. then I see the thyroid gland is really moved up, then go down. So now, one thing, when it is atrophy, a place may collect is not fibrous, it collect fluid because this part is still patent, it is not fibrosed, and it looks like a simple cyst. Where are you going to see it? It is a bump. Where? In the midline. Lot of times they don't know what is it. Usually what they do, they just massage it, right? Unconsciously. So then what happened? It will be infected and pus formation. It may turn into abscess. Patient may come with, "Doctor, what's wrong with me? This is unusual. It wasn't like that. Now it is bigger and congested, red, and it's painful, and local temperature is high." Then doctor will say, "Okay, go for ultrasound." And ultrasound result will come and they say it is infected thyroglossal duct cyst. So this is known as thyroglossal duct cyst. Okay, so it is due to the congenital remnant or patency of the thyroglossal duct, and it collects fluid. That is known as thyroglossal duct cyst. And thyroid gland is connected to the tongue okay, the spelling of the tongue, Tongue, Ton, make a correction please, Tongue, tongue. Okay, connected to the tongue by thyroglossal duct. Thyroglossal duct atrophies after descent of the thyroid gland. So thyroglossal duct atrophies after descent of thyroid gland, and the thyroid gland is the first endocrine gland. It is the first endocrine gland to develop. So now, why it is the first endocrine gland to develop? Because it secretes thyroxine. It secretes the hormone thyroxine. That thyroxine hormone is responsible for the brain development, for the muscle development, and all tissue in the body. Growth and development initially depends on the thyroxine. That's why a baby may born with hyperfunctions of the thyroid gland and hypofunctions of the thyroid gland. Sometimes you will see